I'm about to introduce Laura Galbreath, who's going to be our next speaker. And she's going to be addressing workforce concerns in terms of behavioral health integration. And something certainly dear to my heart. I've been involved with the Maryland Addiction Directors Council Workforce Development Committee, and we are a very strong group and certainly welcome new members and new partners to our Workforce Development Committee. But there is such a great need. We need all the help that we can get, and so very pleased to have Laura here today to speak to us in this regard. I had just a sense, and I don't know, I'm wondering, I'm guessing that some of you folks may be able to identify with pulling up to Mickey D's for a quick meal, and just as you get up and get ready to get out of the car to go in and get something to eat, one or two bus loads of tour buses of high school kids pull up and they start piling out of the buses. And you know that there are about 3 or 4 servers that are inside Mickey D's, and the pandemonium that gets caused, and you just start groaning knowing what it's going to be like in terms of the wait. And that's sort of what I was envisioning as we think about the access to care, that prior to the integration, we're already having humongous access concerns. I know on the Eastern Shore, in particular with mental health, there's grave concerns in terms of the crisis of access and workforce demands and concerns. So glad to have some expertise from Laura today. In introducing her, she serves as the Deputy Director for the National SAMHSA Center for Integrated Health Solutions. She co-leads several learning communities, providing group consultation and leveraging expertise and resources to improve screening and referrals to mental health treatment, creating structures for collaborative care for shared patients, and increasing access to primary care services for persons with mental illnesses and addictions. Prior to joining the National Council, Ms. Galbreath served as Senior Director of Healthcare Reform at Mental Health America. During her tenure there, she conducted state policy issue tracking and analysis, technical assistance, and facilitated state, local, or multi-state advocacy meetings on a range of issues, including Medicaid reform, mental health insurance parity, Medicare Part D, and healthcare reform. She has extensive experience in health policy analysis, community organizing, and project management. Her previous experience also includes lobbying for mental health issues in the state of Georgia, conducting advocacy training for consumers and mental health advocates, and leading issue-based campaigns for private and not-for-profit organizations. Please help me give a round of applause and welcome to Ms. Galbreath.
I think I need to spice up that intro, throw in some fun activities and events about myself. It's a pleasure to be here with you today. I wanted to, hopefully I saw some folks got some snacks, some cookies, some sodas, and things like that, keep us caffeinated for the afternoon, and our discussion about workforce, which should be a lot of fun. And I really want this to be a discussion, I think, because there are a lot of questions you have, questions I have, and questions we have at the state, the federal, and the local level about what does all this mean for a workforce. So as much as possible, I really want to encourage us to have a dialogue because no one has the answer, no one knows exactly where things are going to be transitioning. So let's kind of think about this together, and I hope that you leave today with just a couple of ideas in terms of questions you can go back and ask your staff, your organization, your board, your boss, in terms of, have we thought about this? Do we know this piece of data? It'd be helpful around the ideas of workforce. So I have to do the intro about the center. This is a technical assistance center. It's run out of the National Council for Community Behavioral Health Care. And it is jointly funded by SAMHSA and HRSA, which to me is pretty amazing that we've got 2 federal agencies that jointly funded this, and really think that, wow, the integration of behavioral health, mental health, and substance use with primary care is so essential. And so we're really excited that they were able to bring this entity together. And really we're about planning and development of integration, and we talk about this bi-directionally. So, our goal as a technical assistance center is to be thinking about integration from both in terms of for primary care, how are they better integrating substance use and mental health treatment to serve their population, but also for mental health and addiction providers, how are we integrating primary care to serve the folks that have the highest need. And part of our purpose here, you see, is to provide technical assistance to PBHCI grantees. There are 64 of them currently, one in Maryland with Family Services over here. I may be referencing them later and ask them to respond and share their thoughts as well. But these organizations received funding to integrate primary care services. Some back in 2009, some more recently. How many of you have seen the RFA for the new round of integration grants? There's a couple of you. I really encourage you, if you have not, to go to SAMHSA's grants page and to look it up. It will be probably 32 organizations will get funding for about $400,000 per year for 4 years to integrate primary care. Now, the legislation that Congress passed is very clear that it has to be on-site serving people with serious mental illness because the program started really thinking about the high rates of mortality and morbidity in terms of SMI and cardiovascular disease and so forth. But if you are a substance use provider who is also licensed as a mental health provider, you should be able to apply for this. And there's all kinds of FAQs, there's a webinar and a recording available, so I encourage you to learn more and see if that's an opportunity for you. So the center, we're dedicated to lots of different things. We provide technical assistance. I really want to point to item number 4, and what I'll be getting to later that I'm really excited about is, we've only been up and running for about 1.5 years now, which is not very long for creating an infrastructure, especially when you have big federal projects. And we're developing some really interesting curriculums that I think are going to be really important for the workforce. And so I'm really excited to share those with you, get your thoughts, and letting you know about the availability of those curriculums for the workforce. So thinking about the looking glass, if we were able to kind of look into the future, what does this all mean? I think Mady Chalk, who we work with quite a bit, and talking about healthcare reform and what will really happen, and I think probably Mady did a great job of explaining that even if the legislation doesn't go through, there will be changes happening. There's so much momentum, things will be happening. It'll just be much more on a state level than on a federal level, potentially, if things don't progress at that rate at the federal level. But I think, for me, the question is, there's a lot of spotlight on this idea of integration of primary care with behavioral health. So it's an exciting time, but it brings a lot of questions, being this, target of, wow, let's better integrate care, we're gonna improve cost, quality, and I think it adds a lot of questions for us that we need to be thinking about. And then will the states take the role in terms of workforce development? We'll talk a little bit specifically about Maryland, because I do think you have some advantages to some other states in terms of some actual action in this area. But there's a lot of questions still to be answered and for us to think about in terms of what do we need to be talking to our state officials about when it comes to the need of our workforce. And then what are some of the responsibilities under the person-centered health home? And that's what I'm referring to. A lot of times you'll hear it as the medical home. How many of you feel comfortable and familiar with the concepts of the medical home? Has it been drained into your heads? I see some hands. I really encourage you, if you don't feel like you kind of have it at the tip of your hand, to be able to explain to your colleagues what is a medical home. Glad to send you some resources, websites, nice little pretty descriptions, but I think it's an important concept because it has a huge impact for our workforce. They see this as a way of delivering care for the entire population, so that one day all of us will be in a health home. And to give you just a quick example of kind of what that looks like, my physician's office is a medical home, NCQA recognized. And so you're like, well, what does that look like? So for me, I call and I'm sick and I'm not feeling well. Instead of saying, well, sorry, you have to go to the ER or you have to go to the walk-in clinic, they're like, okay, we have some open slots, we can get you in this afternoon, or we can get you in tomorrow morning. So it's this idea of open access. That there is a care plan for me, talking about my health and wellness and that it's led by a physician. E-prescribing, that the doctor can, with a click of a button, send the prescription off to my local CVS, And before I can make it home, I'm getting a phone call from CVS saying that my prescription is filled. Seems like a simple thing, but it's been proven to show that it helps people with adherence and actually picking up their medication and getting it. I think the one that was most astounding to me was when I actually missed an appointment and a nurse called me twice to say, hey Laura, you missed your appointment, want to make sure everything's okay, do you need to come back in? I'm glad to fit you in. These are things we think of as standards of care, but they're not, and that under the medical home, those are some of the assumptions. And why I want to mention it as well, and why it's so important for us to think about and to understand is on the workforce. If that is a standard of care for kind of general care for the population, there are elements in there that staff are going to need to know. And if our staff in the behavioral health are working in primary care, what is it they need to be thinking about? So, if he's doing e-prescribing, that means they probably have an electronic medical record, and I may have to do concurrent documentation. Wow, I'm an addiction counselor, and I'm sitting in an exam room with somebody trying to do some motivational interviewing with them, and I'm at the same time going to have to try to take notes. That's a new skill set that I'm going to have to be thinking about and be prepared for. So that's just one area in terms of thinking about this notion of a medical home. So I want to talk a little bit about the environment. We're going to talk really big, and then I really want to dive in deeper in terms of our readiness, about what's needed for success in this kind of changing landscape. And again, what are some of the questions we can be thinking about and discussing, both for ourselves as organizations, clinicians, and part of the bigger healthcare system. So I just want to point out, it's not just us and our organization, our county, in this country. It is a global issue around healthcare. And this is really an underestimate. World Health Organization says 4.3 million. And when they're looking at that, they're looking at a very narrow scope in terms of kind of core services that need to be available for a population. But what they are thinking about is, when we think about the workforce, it isn't just a doctor, a nurse, or in our case, a psychologist, psychiatrist. It is a administrative staff. If you're going to have a medical practice or a practice, you need administrative staff. Leadership. How many of our CEOs are going to be looking to retire in the next 10 years? And what does that mean in terms of a new workforce and leadership for our field? So when we talk about the workforce, we've got to think a lot more broadly in terms of both the administrative, the clinical, and also then I think, for our field, thinking about the role of consumers and individuals in recovery. And what I think this was, to me, one of the most shocking things was that the workforce shortage has replaced system financing as the most serious obstacle. I'm like, really? I thought money was always the biggest problem when we're talking about services. And for the World Health Organization to say, actually, it's that we don't have enough folks to provide the services is really challenging. This is a great way of rethinking about, what is a health workforce shortage? I think a lot of people just kind of have assumptions about this, but I think there's multiple ways to think about it. And we've got to think about, that there are too few health workers being trained. And I want to be clear, when I say health, I really am talking health and behavioral health, because we are part of the system. Too few workers willing to work in our health system. I really want us to talk a little bit more about that today while we're together, because it's a big issue for us in terms of, in addition to not enough folks being trained. And then too few jobs for health workers. I really think the middle one is the concern and area we really need to focus on, but it's really important for us to think about each of these. So it's a very long quote, but I think it's a really strong one, and I want to just highlight the second half that says, the United States need not necessarily train ever-increasing number of health workers, but rather it is at the right moment to reconstitute its health workforce composition, determining the best mix of health workers needed to keep America well and care for those who are sick. Just like we talked about, there's no new money, and how can we restructure and think about better uses of our money, we have to think about the workforce. We can't just train more nurses, more doctors, more psychologists, more psychiatrists, more counselors. We've got to really think about, how do we think about shifting roles and responsibilities for folks? And then that's where we can really think about, what are then other training needs if they're going to reshift. So what does that mean? I mentioned the example earlier. What does that mean for an addiction counselor to reshift and maybe work a couple of days a week in a primary care setting? It's maybe the same skill set, But we'll talk a little bit more about what are the different elements and the cultural shifts. And it sounds easy, but it's actually really difficult in terms of that environment. And also then identifying, well, who's, you may have some staff that would naturally work in that environment very well. They're accustomed to change, they like fast pace, they're always like, who's the next client? What's the next project I can work on? Whereas, other staff you have may not be as suited in that kind of environment. So part of it is actually kind of figuring out, who's the best fit, where, and when. So a growing service economy and a demand for skilled customer-oriented staff. And I want to talk about this from two perspectives. One is our competition with other sectors, and then our competition within our own healthcare sector. So, there's a growing service economy. More and more we're buying things that are manufactured elsewhere, but we're purchasing services that are done locally. And so the pictures I show here, we've got someone who's a file clerk in a medical office, someone in the food industry, the spa, more and more we are moving to a service economy. And what does that mean? You have to have a workforce that is customer-oriented. So, other industries are going to be looking for people that know how to sell a service, that know how to be responsive to a client and meet their needs and kind of anticipate what their needs are and where they're going. Well, isn't that the same workforce we need? We need people that can help somebody who's in recovery and reaching and striving for their next wellness goal, or in terms of helping them get into housing and how we can finesse those relationships in the community to be able to get the services our folks need. So, there's a real need. There are only so many people that are kind of good at that skill set. And, how are we going to be competing with other sectors? When someone decides to be a physical therapist or to work at a spa versus working in our community services or our group homes, or, so it's something we have to think about in terms of that customer orientation. The other piece, within our own industry, if I'm talking about an addiction counselor working in primary care, why wouldn't maybe a primary care person just hire them directly instead of contracting and working with us? Obviously, we don't necessarily support that because you need that full continuum and you need that warm handoff to be able to, when somebody needs more intensive services. What if someone relapses and they need to get into detox and other things? But so how are we going to have competition within our own sector? And that may not be just behavioral health against primary care or hospitals, but even within behavioral health. If we have an expanding pool of people in which we're providing care, so think about post-healthcare reform, and all of a sudden all these folks have access to insurance, and one of those benefits is a mental health or an addiction benefit, they have more choice in terms of the services and where they can get those. And they may decide, instead of going over to our shop because it's not in as friendly looking an environment, or that they're not very nice to me when I come in at the front desk, or I have to wait too long, they may have the option and more competition down the street. And so as they have more choice, that also means that we need to be thinking about, as our workforce, how are they providing good, again, consumer-oriented services in a way that makes us competitive in our community. Any thoughts or questions about the idea of competition? Any big fears that people have around what I've said so far, or anything around the shortage? Yes, ma'am.
So we are an integrated primary care and behavioral health program, and the shortage of, and we're in DC, the shortage of substance abuse counselors. So we have an open position, and I got 30 applicants, and none of them were qualified to provide the services. And it's such a big issue, and DC is now sort of getting to the point where they're professionalizing substance abuse, a little bit behind the ball of other parts of the country. But and so, do you have any suggestions for how? We thought about filling it with. We have filled the role with social workers in the past. We filled it with nurses in the past, but there's something about having a substance abuse counselor that's, been trained as a substance abuse counselor on the team, and so we're kind of struggling. Do you have any suggestions or advice or things that other people have done in the past?
So great question. Let me try to summarize it for those of you in the back of the room that may have not heard that. So they're an integrated behavioral health organization in DC, and they had a position for an addiction counselor. 30 plus applicants, but none really met the qualifications that they needed to be able to do that. So now they're having to rely on other folks like social workers or other staff. And so the question is, what is it we can do? We want to hire addiction counselors. Are there resources out there or strategies? I'd say if you look at integration and workforce, the whole area of addiction, in terms of addictions counselors working in primary care and their workforce needs, is the newest in terms of the evolution. So there isn't a clear answer. I will talk a little bit later about a curriculum that we've just started developing. I don't even have a slide on it yet, but I'll talk about that when I talk about some of the other curriculums for addiction counselors. I think part of it is on-the-job training. Until we know how long research to practice in terms of 10 plus years. I think it's the same way sometimes when it comes to our educational institutions and preparing workforce for the realities of today. So, how many of you have had to do pretty extensive on-the-job training for folks that you hire, even though they've got the basic qualifications? So I think, part of it is how do we share and utilize those resources around, okay, I know someone's not gonna have all the qualifications, but I'm gonna hire them, and then here's kind of the core competencies that we're gonna work on. And we are working on the development of some core competencies. We've just started with 2, and then we'll be growing, so I'll be talking a little bit more about that. So I saw some hands. One other question, and then I wanna keep going on some of the conversation. Yes?
Well, on a previous slide where you listed some points about the workforce shortage,
Yes.
I think if I'm not mistaken, the last point was one of the problems is there's a shortage of jobs. So how do those two things match up? If there's a shortage of jobs
And a shortage of workforce. So the supply and the demand question is that, do we have too many of one profession? And that's really where the crux of it is. So her question was about this slide where we had on the bottom too few jobs for health workers. To me, the crux is around, for some professions, we have too much supply and not enough demand. So in primary care, I would say the areas, we have a huge demand when it comes to actually primary care doctors, internists, family physicians. Do we have a huge demand for cardiologists? Thank you, cardiologists specializing in children under the age of 3. This whole idea in terms of specialty, it's been great, but we have a high demand when it comes to primary care. I want to say a statistic I heard was out of a graduating class of 300 out of the University of Alabama's medical school, less than 20 were deciding to go into family practice. And the rest were going into specialty. So I think it really gets to which professions do we have a large supply of, and then, if we do have a supply, again, how do we retweak what they're doing to really match our needs? Yes. I'll take one more, yes.
Thank you. When we say too few jobs for health workers, I think this question is tied to the financial capability of the organization. Let's say a small health department or some government agency, we're always cash-strapped. But, I think, in the same vein as what you said, we do get a lot of applications for new positions that do open up if we get a special kind of allocation for a new staff person. What happens is we get a lot of applications, but the applicants are not qualified for that particular position. Now, what I was just came to my mind is that training existing staff, you said it's a growing consumer-oriented service economy.
Yeah.
But most of the workforce that's here, that has not retired yet, I do not exactly see them as totally consumer-oriented.
Yes.
Or those qualifications that are necessary, let's say if you are trying to do an integrated health home, okay? And we are integrating substance abuse with mental health counseling with primary care. So training, cross-training of existing staff base. And we do that a lot. Like she said, we train everybody very intensively. But if I'm the supervisor, I have a full-time job, and I'm training somebody which becomes another full-time job, how much can I impart? So, some kind of a structured curriculum, just like, teachers in the school system have a professional development day every so often, and there's a state curriculum to kind of ensure their progress. That could be a great help to us to train these people, not only in the field, but also cross-train in the other fields.
That's a great point. So I want to address this, and then we'll keep going and come back to some of this. So what she was talking about was the notion that I've got the positions, or I did, before my budget got cut. And so that there is a demand, but I may not have the funding for those resources. And then again, to the issue of they may not be qualified when they do come in. And so you try to take your existing workforce and try to see how can we cross-train them. But that there isn't really kind of a standard curriculum, and there's a lot of challenge for supervisors. That's the other piece of this. You can hire staff, but then what do you have to have people to supervise them. And what tools do they have to be able to both supervise and train, so that you're not having to create it all yourself. So there's some curriculums there. So I think we've got some things that are under the works that we'll talk about that I think will be helpful, but I think there's a lot more that needs to be done. And I think what we need to do also is take innovation from the field. You guys are doing some really innovative work. Why aren't we taking some of that and just disseminating it and replicating it out? That's one of my big goals for our website is I don't want to create a whole bunch of new resources. I want to take the actual tools you've created and successfully used in your community and bring them up and disseminate them to more. So I think that's a huge thing that we need to be thinking about. So we talked about kind of the competition. I think we have to acknowledge the value of money. A recent study came out where they interviewed graduates, and 80% of them, compared to the past, expect to be financially well off. There's an expectation now that if I go to college, that my goal is I want to be financially well. Now that may not be, financially well is defined differently. It may not be driving a BMW, but that I can afford, a car and a house and, a standard of living that is acceptable in our, the American dream of the middle class. So, but I think we have to acknowledge the issue around salary and compensation. If we're talking about shortages, if we're talking about a changing workforce, and I think in our field, this is a salary survey that was done last year. I think it's very telling and something we have to be thinking about and having conversations with. One, a direct care worker in a 24-hour residential treatment center has a lower median salary than an assistant manager at Burger King. That's a shame. When you think about someone who could be really work successfully and has a relationship with clients, but when it comes down to a difference of $2,000 a year, that's a big difference in terms of your salary, and that you could actually be working at a Burger King. It's frustrating, and I think it's frustrating for all of us as clinicians or supervisors or CEOs because we are facing so many budget cuts. A social worker with a master's degree employed in a mental health addiction organization will earn less likely than a peer working at a general healthcare agency. Again, that gets to some of the competition. I want to partner with my health center, but it's hard when there's a sense of they're taking our staff, they're paying them more, they're offering them better benefits than I can offer. We can't think of it that way. We've got to kind of partner and see how we can offer different incentives. And I don't know how many of you were at the National Council's conference or have read any of Daniel Pink's book. I mean, he's got some amazing things around motivation and what really motivates folks that I really encourage some follow-up. And then lastly, a registered nurse working in behavioral health compared to the national average of a nurse is a difference of, about $24,000. I mean, that's huge in terms of trying to, especially as we try to integrate. If you're trying to hire a nurse to come to work on site that A, is skilled, and B, has a comfort and that kind of customer service orientation to work with our clients, and we can't compete with other industry. Workforce disparities. I think we cannot also forget that even though 30% roughly of the population are minority populations, if you look at the actual workforce, there's a disparity there. Less so when it comes around psychiatrists at 24%, but I think if you look at social workers, school psychologists, psychiatric nurses, at only 10% of all psychiatric nurses come from a diverse background. So I think this is from a clinician's, but I also want to talk about the role of leadership. You know, how many of our CEOs, our executive C-suite, you know, CEOs, CFOs, our chief medical operations, clinicians, are people of diverse backgrounds. How are we thinking about our middle managers who are diverse because, you know, they've kind of grown from being maybe a social worker to then a supervisor? How do we also continue to build that career ladder to the C-suite? At the National Council, totally separate from this Technical Assistance Center, I'm really pleased and excited about one of the projects that we've had for the last several years that is a leadership program for middle managers, primarily a lot of African Americans and a few others from different ethnic populations that are, and what we've taken is a year-long program to help them be mentored and receive skills to help them grow. And we actually saw one this past year take on the CEO position, and that was really exciting to kind of be able to see somebody be able to move into that level and to get the support. So thinking about both in terms of our clinical staff, but also from our executive leadership, who can we grow and so that we're more representative of the people in our communities that we're serving. Tipping point, I mean, I think you all know this, it feels like it's been a conversation now for a couple of years. These are the points that SAMHSA really articulates whenever you see a SAMHSA presentation, that behavioral health is essential to health, prevention, early intervention is possible, treatment is effective, and people recover. I'm really excited because, as you heard, when I used to work in Georgia and you talk about state parity, you know, you'd have to make this case that mental health and addictions is essential to overall health, that you're not going to manage somebody's physical health if they have a comorbid addiction. And so I was shocked, I guess a couple of years ago, we went and had this meeting and I was all ready to make my philosophical argument about the mind and the body and they're connected. And they're like, oh yeah, no, we completely get that. We totally think that behavioral health needs to be part of this medical home. I was like, oh my God, I just lost half of my presentation here because you already get it. I think the devil is in the details. Because then you go back and you say, that's great. What does that look like? That's the big question. So I think we are at a tipping point in terms of the recognition to look at someone's whole health. It again is we need to think about being at the table so we can frame that and make sure it really looks the way that we think and that recovery is embedded. One of the things I'm really excited about, just on a side note, is HRSA, which is the federal agency that really oversees all the federal qualified health centers. They've come to us and they said, we want to know more about recovery. What is recovery? What would recovery look like in a primary care setting? How would we articulate that? Who would be part of it? I mean, they're really interested and excited to see the development that we've had over the past 10 to 20 years around the recovery movement. So I think it's an exciting time. We just have a lot of work to do, and I think part of it is just sitting down and having that conversation, because we're like, I don't have an example of a great health center that has fully adopted the idea of recovery. Maybe they've taken on pieces, but you know, as a comprehensive part of what they do. It's, I think some of it's already embedded in some of their philosophies, but there are a lot of pieces that are missing. So it's a great and exciting opportunity. So I think we have to think about this as a real tipping point and an opportunity for us versus just challenges. Let's also think of those opportunities. Triple AIM, there's a wealth. If you just Google the triple AIM right now, you'll find a ton of information on this, but it's really kind of an underpinning of healthcare that I think we need to think about, so that when we're talking with hospital systems, our state legislators, all kinds of people, and we talk about the services that we're in, we have to talk about the triple AIM in terms of, are we helping to reduce costs? You know, by keeping that addict out of their emergency room every week, we're helping to reduce the healthcare cost. By doing innovative recovery services and actually going into the home and working with the individual and the family, we're providing quality care. and that we're providing access so that we can better serve those folks that do not have Medicaid, do not have access to the state funding via block grant or other kind of social services. How are we expanding and providing access to the population of folks that we're addressing? So just want to point this out just in terms of kind of something to think about as you talk about the work that we're doing with others in the community. So by the numbers, I did pull this up. I want to talk a little bit about one opportunity around the National Health Service Corps. And I pulled up some numbers for Maryland, and as you can see, there are currently 137 health professional shortage areas. And this they do by geography, demographics, by systems like lack of hospitals or other services in an area. And so as you can see, there's 51 in primary care, 42 in mental health, and 39 in dental. This is a real opportunity because by having this shortage, there are federal programs that you can access. And I have to say up front that they're not as easily accessible for an addiction-only provider. Your real opportunity is when you are integrated, both with behavioral health and when you're building your partnerships with primary care and others in the community. But the National Health Service Corps, what is it? It's a great network of health professionals that provide medical, dental, but in exchange for the services, they get financial support in the terms of loan repayment and scholarships. Why this is important? Recruitment. If you're an addiction treatment provider organization and you need a physician to be able to do physical exams, this is an opportunity to help you through partnerships and being designated as a agency under the National Health Service Corps to use this as a recruitment tool. And it really, really is very helpful. It's not easy in terms of getting through the process, but it is a tool. And one, if you do have partners, you can talk to your primary care partner and say, hey, by the way, are you part of this National Health Service Corps? Do you have any clinicians that are part of this? And when it comes to behavioral health, it does not include addiction counselors yet. Let's advocate at the federal level to expand that. But it does include psychiatrists, licensed social workers, kind of about 5 to 6 different professions. So if you're looking to better integrate with mental health and primary care, it's a great opportunity. And on the resources, a guide that we've created that kind of helps walk you through this system. And I just wanted to give you 5 tips if you decide to go after this, is really just making sure that you understand what it really is before you go out and apply. 2 is just to confirm your area, so kind of understanding where your area is in terms of within the state need, and then contacting the state primary care office. Just like we're a national technical assistance center helping grantees like family services and others, your state primary care office, they're tasked with providing assistance in understanding this National Health Service Corps. So maybe you and your partner could go in together, have a call with them and see if there's some opportunity to help you get some staff. And again, it's medical, behavioral health, and dental. And I think the dental piece is, we're gonna hear a lot more about that. I think as these grantees that are integrating primary care, it's a huge need, and there is no clear funding source. And there's such a workforce shortage in terms of access to dental care. It's great that I can do a blood pressure screen for you now, but sorry, you still have to go to the dentist and get an extraction. You can't just get a simple root canal, but you can't get services, it has to be an extraction. So I think we'll see a lot of movement in that area, and that has huge implications for the folks we serve. So I would love to know, is anybody here read this report, or I know there's a YouTube video. Would you mind just saying, from your perspective, what's your one-sentence elevator speech, if you're in the elevator, about what you've heard about this report?
It's a comprehensive report that focuses a lot on the primary care physician issue, and not very much with behavioral health.
That's great. Any other perspectives of, I should repeat that, I'm sorry. It's a report looking at workforce, primarily around primary care shortages, physician shortage. It is a comprehensive plan for the state of Maryland. And there's actually a YouTube video with your Lieutenant Governor and several others in a hospital exam room with a fake person in the bed releasing this report. But what I have to say is, while it is focused on primary care, there is I actually did a search in the PDF. There is not a mention of behavioral health in there, but those efforts around licensure, additional funding under Medicaid in terms of reimbursement rates, other loan repayment programs, all of those are opportunities that we can kind of take advantage of. It's like, great, we put your focus here. How can we take advantage of it? Or how can I come and talk to you about our needs? And if we're going to be, part of this healthcare, we're part of primary care, here's what I need to help our addictions workforce, our social workers, our peer support specialists to be able to be better integrated into care and to address those workforce needs. So it's to me, it's a great conversation starter and a really great resource. And I have not seen this kind of comprehensive report in some of the other states I've been looking at. So, kudos for Maryland to bringing this attention. And I'd say let's go out there and take advantage of it. And again, I think it's conversations. It can be a simple phone call. If you're a CEO, maybe calling this office or some of your other contacts in the community. Again, if you have primary care, to say, hey, are you taking advantage of some of this, or do you happen to know somebody that's on that board? I'd love 5 minutes of their time to talk about what they're doing and maybe some connection with the work that we're doing to serve folks with addictions. Anybody have any of those relationships here that we could, you'd be willing to leverage in terms of somebody in primary care that is doing some of this work on workforce? You raised your hand. Are there others in the primary care? Maybe our FQHC friend here, you're familiar with this report? No, it's new. And this was brand new. Let me just say it was released in November. So it is a special opportunity. Yeah.
I just wanted to share that the person in the room who read the report is the new MATSE workforce consultant. So she is working hard to seize all those opportunities and is making those phone calls and contacts that you just mentioned. So
that's perfect.
Everybody get involved and help us take those meetings.
Great. Yeah, and I think like she was saying, when you get the phone call and ask to join them in a meeting, it really is important. Just like it is at a policy level for the on-the-ground providers to be joining, when you go to the state capitol or when you go to Washington on the Hill, it's just as essential when we're meeting with those regulatory and state agency folks to have actual providers there to kind of have that real-world experience. So I really encourage you to join them in having those meetings. So this is what we've done in terms of thinking about, so the center we had the Annapolis Coalition and John Morris with the lead and helping us to kind of think about what are some of the strategies if you think about integration for the workforce. So, we talk about the expanding role of consumers and families to participate in, direct, and accept responsibility for their own care. And it's a whole big piece of the workforce. I mean, how many of our addiction counselors, our peer support specialists, and how are we maximizing their skill set in an integrated setting? And one example I'll go ahead and give you that we'll mention later in the form of a curriculum is some sites, they've trained their peer support specialists to do kind of more whole health and to create a health goal. And by sitting down with a client and creating a health goal that can then be implemented and integrated into their treatment plan, their time doing those services are billable. So that's an exciting opportunity. Here you have people in recovery, you have consumers, by taking on a piece of the role when it comes to integrating primary care, how is that an opportunity then to bill and finance and make their role in larger organizations sustainable? So some other things, expanding the role of communities to identify local needs. One of the greatest, I went and visited the site and they've integrated primary care and they've got a great partnership with their local FQHC. But they decided, well, let's build a gym. Let's build a kitchen and have nursing or nutrition classes. Let's go out and get mammography, somebody come in and do mammograms for our clients. And so instead of taking this huge burden of doing it all yourself, how are we leveraging those resources in the community? Just like we're trying to take advantage of free things. I got a flyer the other day about a health fair in my local community. I was like, I actually might go down there and take advantage of that. Why aren't we thinking about bringing our clients down to that health fair and taking advantage of it? Asking that mammography van that the health center has to come on site and to provide services. What are some of the hot topics right now that are getting funding when you think about public health? Childhood obesity. So many, it's such a critical need in our community. How many of our clients that we're serving are adolescents that are either currently obese or on their way to becoming obese because of medications or other, things that are happening in their life? How can we take advantage of those community resources? So again, it's not just saying, okay, I need to hire a wellness coordinator to come on board and do all this work. How can I take those other resources out in the community and maximize them? And so maybe, you do have that energetic case manager who's right out of school, who's just, wants to change the world and help everybody. Give them a couple of these small projects. And so you can accomplish your mission, and really you're not hiring new staff. You're just kind of maximizing the energy of the staff you currently have. Obviously there's a lot that needs to happen at the federal, state, and local around recruitment and retention. Again, that's why it's so important to get involved in your state if there's some initiatives or if there are other local strategies. And then increasing the relevance and effectiveness of training and education. I want to share with you some curriculums that I think you'll be really excited about, and then leadership among all segments of the workforce. Sometimes I feel like, we talk about how we've been siloed. I think sometimes we silo ourselves. We tell case managers, you can't be afraid to call a doctor's office and talk about a shared client. You're part of the healthcare team. You have just as much of a right. We have, as a community, just as much of a right to be part of these conversations when it comes to workforce and the resources and the training and leveraging your local universities. And Maryland is fortunate compared to some other states in terms of having some great educational institutions. How can we better leverage the training programs and internships and things of that nature? To give you one example, one of the grantees we're working with, I thought they were doing really something interesting. They have a local school of pharmacy, and they have 3 pharmacy students working at their site on a lot of their wellness goals, doing health assessments, helping with med management, doing some patient education. And I'm like, I never would have thought of using a pharmacy student from a local pharmacy school to support them in doing their work. But again, it's what's in the community, what can you leverage? How many of you does anybody want to share any good examples? I'd love to hear if you've utilized anything in the community of like a local pharmacy or other services. I know a lot of you have connections with hospitals.
Nursing students.
Nursing students?
Yeah.
How are you using your nursing students?
It's an inpatient program, so we ask the nursing students to come and help with the patients, and they are mentored by our nurses.
Curious, have any of them stayed after their internship?
I have hired a lot of them.
Ah, so you use it as a recruitment tool. You've actually hired them. I love that. Yes, ma'am.
Yeah, the same, nursing students, a couple of things. So we have a couple of the nursing students who live near our recovery house, and so she actually walks to get the clients, and they all walk together, and and as she's walking along, she'll do education on diabetes and other common illnesses. She also will work with the clients to advocate and to ask doctors the questions that they want to ask, and show them how to write those questions down and do education like that.
That's great. So you're using nursing students to actually go to the residential facility, pick them up to walk together to get their services, and do patient education and help them in self-management and going to that doctor's office. Yes, ma'am.
So we have there's a psychology internship program at the VA, and we have a big psychiatric rehab center and a residential program. So the psych interns come and spend a year of their training working with our staff, teaching independent living skills and social skills. So not only are the clients and members getting this great service, all under supervision of experts, but then the rehab staff are learning those same skills and co-leading some of those interventions. So it really works out nicely.
So you've used it both in terms of providing services, but then also cross-training your other staff. That's great. And there's a lot of work that can be done. We've seen sites with their nurses start training consumers and case managers on, how to take a blood pressure. You can get the self-monitoring cuffs where you just, put them on correctly and push the button, and they can be able to help do that monitoring. So that's great cross-training. Other great programs that you guys have used? Well, thank you. Those are some really good examples. And so we've talked about leadership and then infrastructure to support and coordinate workforce development. And to me, that's where we really get to how do we share information in terms of innovative programs like, using nursing students. Is the university open to sending more nursing students over to another center? Or how do we get those training manuals for your supervisors in kind of a common place so that they can access them? One of the things that when we worked with case managers recently is they asked their organization if they could have a folder on their shared drive with all these tips and tools that they hand out clients, because someone may have found one night something great on the CDC website about self-monitoring of medications. And they start using it with their clients. Well, how can we make sure that they can share it with their other colleagues? And so they've created a whole folder with these kind of patient education tools that they can share among staff. So 10 ways states can respond. This is really just some more food for thought, for fodder. Career ladders, we have to be thinking of, and we really would love to do some more work on this. We're a little limited in terms of the center's ability to do a lot of workforce in year 3 and 4 for our work, but I think the area of career ladders and kind of building those stepping stones, especially for our consumers and individuals in recovery, how do we support them if they are an addiction treatment provider and they want to become licensed or they want to become a psychologist or another profession? How are we supporting them going up that ladder? High school oriented to health careers. We're all kids. I want to be a reality TV star now. I want to be a police officer. I want to be a doctor. How do we talk about other professions in the health career services area that people can take advantage of, both very early on in high school? Educational programs, we've heard a lot of this. And what we talked about earlier is this training for supervisors and managers. We cannot forget the folks that are put into these positions of supervisory roles. Just because you're a supervisor now doesn't mean that you have automatically all the schools and tools to be able to help your team. So I think we've got to really surround them as well in giving them those resources. And so this is all part of a broader paper that we have on our website if you want to learn more. Really, again, encourage you to take some of this so that when you do have those conversations with your policy leaders and community leaders, you've got the data and strategies you can share with them. So we've already really talked about this in terms of looking at kind of strategically what needs to be done. We've talked about being at the table and what are some of the key components of the strategies. Now I want to talk a little bit, we've talked about as an organization, what is it we need to do? I want to talk a little bit about individuals and what is the work that we can do to support individuals in the field. What are some of the challenges? I think, I talked a little bit about, wow, working in a primary care environment. It's so fast-paced. For a lot of folks, this idea of a 50-minute appointment or an assessment, you can't do that in a primary care environment. You may have a doctor interrupt you in an exam room to say, hey, I have another client over here who's in crisis and really needs you to come and help them out for a minute. You may only have 15 minutes. There are some great billing codes out there that support like diabetes management. So if you're working with a client in a primary care, but that's only a 15-minute increment. So it does require a different way as individual staff to work in these different environments. And facilitating client self-care, how do we help folks to really self-manage their care? I'm intrigued and I love reading all this great stuff about mobile apps. And obviously the people we serve have huge disparities in terms of access to cell phones and smartphones, but my thought and what I see in the next 5 to 10 years is that everyone will have access to smartphones and what are some of those interesting things that are happening now that we're using. So just to give you an example, I have a whole cadre of apps now. One is to track my what I eat every day, and it has a barcode scanner, so I can scan the barcode and it tracks all the calories, protein, salt intake. I also have an app for sleeping. It records my sleeping patterns and gives me a report the next day that I can Facebook or email to my doctor that shows, wow, Laura, you are not sleeping at 3 in the morning every night. What's going on here? There's an actual app that you can have on your phone. You push your finger on the camera and it takes your pulse just by putting your finger over the light on your camera. So I think we need to be thinking of, yes, there's these great technology tools, and they may eventually be available to more people down the road, but what are other ways we can help people to self-manage? We do that very well in terms of thinking about a recovery goal and what are some actionable items. We have to be thinking about their whole health. If their goal is to stop smoking, what are some of those steps that we can do to help them self-manage? What are, again, those community resources, free patches, quit cards, other programs that people can take advantage of? And speaking of tobacco, I just want to say in terms of our workforce, I think a huge challenge is, I mentioned these new PBHCI grants and said to go check them out. One of the requirements you're going to notice is that if you get the grant, you have to agree that you're becoming a smoke-free campus. That's huge because, second behind our consumers that are smoking are our staff that are smoking. So, it's great, we're going to do this, we're going to help improve the health and wellness of the clients we serve, but guess what? How many of your staff are going to really be upset that now they can't smoke either, and how is that infringing on their rights? So it's a huge factor in terms of how do we communicate that with our staff and bring them the same resources we do to our clients. If they decide that they're ready to quit, how do we support them in doing that? I talked about concurrent documentation. That's another huge issue. If you're going to have an electronic medical record, if you're going to be working in smaller, brief times, how am I able to talk to a client and type at the same time? I know some of our doctors have that challenge, but it's key and another kind of training opportunity for an individual. Obviously, the credentialing is a big piece, and there needs to be more strategies and thought and communication about how we can help folks. And then again, we've already talked about the training and comfort in diverse treatment settings. So I want to talk, we've talked about shortage, we've talked about the need of, there's so many different pieces when it comes to workforce, increasing the diversity of our field and leadership development. I love the saying that there's only one way to get development and it's one piece at a time. So what I want to highlight for you now are some curriculums that are under development or being piloted right now that will be available to you very shortly. The first one I mentioned earlier to you that there is one that's so brand new I don't have a slide for, and that is specifically for addiction treatment counselors. We have brought together in partnership with the ATTCs, their national office, a wide range of experts that we just had a meeting on to talk about what should be in a curriculum to help addiction treatment providers work in these new environments or work in new ways. So maybe they still work for us, but now we're asking them to look at someone's health goal, to do a blood pressure check, to talk to a doctor's office and communicate about a shared patient. So how are we helping the workforce be prepared? So we anticipate that curriculum, again, we just had the kickoff meeting. Our hope is that by October 1, we have a curriculum that can be piloted out to the field. And so obviously, if any of you would like to be a pilot site for that type of curriculum, let me know. We'd love to include you in that. And so we can kind of make it a really top-notch training program and get it out to the field. Consumers. I talked a little bit about this with WHAM. It's called Whole Health Action Management. And what we're doing, we have the first training of this year coming up next week here in Baltimore, actually, with the PBHCI grantees. It's training consumers to help their peers to be able to create those health and wellness goals. And it's not just like, well, I want to lose 30 pounds in 6 weeks. It's realistic. It's really fine-tuning that goal so that it's incremental, it's measurable, and that you have confidence. And to me, that was really key when I went through the program, was the confidence that I have confidence I'm going to be able to achieve this. And then after creating that goal, which by the way could be incorporated into a treatment plan, is that they get an action plan for success, and they actually get either individual or group work for 6 to 8 weeks. So we think it's a great curriculum for our individuals in recovery and for our consumers to have a critical role as the workforce in integrated settings. And so as you're required to integrate more and more, you can take advantage of this workforce and their skills and really grow their role. And we are starting out with certified peer support specialist, seeing this as a continuing education opportunity. So it's not just for new folks, but it's for folks that are already out there that are expanding their role. Again, rethinking how the work that we do. Psychiatrist. Again, it's a workforce shortage. There are not enough psychiatrists out there, and if you think about child psychiatrists especially. So we're really doing a lot of work with psychiatrists to think about how can they consult. So give you an example. Say you have probably a handful. You've got 6 clients that are very stable on their medications, and I'm really thinking more here mental health. So you've got 6 clients that are stable, they're doing well. Let's have them do their management over in the primary care. Either because they're stable and healthy and they just need to focus on their wellness, or because really the priority right now is their physical health condition. Maybe their diabetes isn't being well managed. But how can that psychiatrist now, instead of having to have a med visit with them, how can they play a role to consult the primary care office? So that that physician feels comfortable taking those 6 clients, providing the physical health care that they need, but knowing that I can call up the psychiatrist and get some advice with clients when I have them. So it's really kind of helping them to change their thinking. Again, changing their thinking about how they do the work they do. And this is really for the current workforce. Our long-term goal is that this will also be in the schools. Because we've got to start from the schools all the way to the folks that are here. And the reality is, just like I mentioned, you might have kind of a newbie case manager that's like excited and is right to work in a primary care environment. You may have psychiatrists that they work the way they work, and this may not work for them. So you have to think about which psychiatrists and which of your staff are able to really be successful in these new models. And what are you committed to in terms of keeping them or looking for new psychiatrists that can work in these new systems? That's a tough decision. Primary care physicians, I think, a huge need. How much stigma is faced by folks when they go to a primary care office? Oh, well, that's just because of your anxiety. Oh, well, that's probably a side effect because you're probably drinking again. Or someone's afraid to talk about their pain medication addiction when they go to the office. There's a lot, plus then the folks that are comorbid. So you've got somebody who's on 4 or 5 drugs because of unmanaged diabetes. They're on medication-assisted treatment for their addiction. MDs need some new training. They may have not been in school for a while, they have their basic education, but they need support too to help manage these multiple conditions and in a way that makes sense and is person-centered. Case managers, a really exciting program around case-to-care managers to see how do we expand the role of our case managers so that they are working with folks on their health goal as well as their recovery goals. And one of the things I noticed is that a lot of folks, well, I already take them to the doctor. But are you doing that for the entire client population that you have? Or are you just doing it for the folks that are already sick? So what is our role? I think about that teenager who really needs some services, mental health services, but hasn't yet developed a comorbid medical condition. How do we help them to prevent that by thinking about their wellness goals? And then social workers. We're really looking at a comprehensive curriculum for the social workers. This is really thinking about for working in a primary care environment. And this will be a web-based curriculum, so we're really excited about this one as well. And then communities. Mental health first aid, Maryland. This is the home of mental health first aid. So we really see this as a tool. As most of you know, this started in Australia for primary care staff. So how are we bringing this to help front desk staff, nurses, physicians, assistants to realize, oh my God, I have a patient here. They're hyperventilating, that she's having a panic attack. In this 1 minute that I have with her in this exam room or in this hallway, can I be helpful? So it's really thinking about how do we bring some of those skill sets to the broader community. And then your strategies. You've given us a couple of examples here. I'd love to hear a few more or some of your questions in terms of the workforce. What did I not address here that we really need to be talking about as we move forward? Yes, ma'am, in the back.
So, thank you. I love this. I'm a primary care physician by training. So, and I've been doing addiction medicine really for the last 10 years. And so I love the fact that primary care physicians, and there's a training curriculum for primary care physicians because keeps growing in terms of the number of primary care physicians who are really interested and also understand the value of themselves being part of the whole treatment and recovery and kind of prevention network for, particularly on the substance abuse side. And the mental health side, you know, it was 25 years ago, 30 years ago that we were kind of there with depression. The one, I guess, question I have for you, so I think what I've heard a lot from my primary care colleagues is that there's not necessarily that idea of kind of this is a chronic disease and or the substance abuse and depression and you know the whole behavioral health kind of continuum is a chronic disease that needs then that self-management over the lifespan. That's not necessarily kind of a very well understood kind of model. And so I wonder whether some of that's going to get addressed in your primary care training curriculum.
Yes, definitely. We definitely see that as a need in terms of the physicians understanding the role of a mental illness or an addiction as a chronic condition that has, you know, that needs to be managed and supported across really the lifespan. So that is a critical piece. But you know, our curriculum is you know, one curriculum. We're going to try to get it out there as much as possible. There really does need to be a lot more around this issue to help physicians to better understand the science behind addictions. Again, what does recovery mean? What does it look like? And I have to say, especially around addictions, you know, primary care, when we're out there talking, they get depression. You know, I can handle somebody who comes in with depression. I can handle somebody with some bipolar and helping them to manage their medications and connecting them to support and to provide some services maybe here. They're really at a loss and looking for partnerships when it comes to addictions. Addiction pain medication seeking, alcohol use, they just really feel at a loss about what to do. So it gets to that old question again, you know, why am I going to screen if I don't feel comfortable treating? And the role of addiction, medication-assisted treatments. Yes?
The second part of my question is, so have you all also partnered or reached out to the AMA, the American College of Physicians, the, you know, other kind of health, physician associations to also try and kind of get them on board? Because a lot of that, they deal with a lot of the educational aspects in the curriculum.
Yeah, no, that's definitely part of our strategy with this particular curriculum. And we've been developing some of these relationships for quite a number of years now because of the medical home. You know, this has been a hot topic, the medical home, for as long as I've been at the National Council, which is coming up close to 5 years now. And, you know, really we've tried to go out there and partner to get to that detail of, well, what does behavioral health look like in a medical home? So, you know, they know us now. We've developed some of those relationships, and we'll definitely be circling around this. But we need others because, you know, this technical assistance center is limited in how much we can really do around workforce. And it demands a bigger attention both, you know, at the state level when you have this great program on workforce to expand that, but then also at the federal level. What resources are available? We really need to advocate, think or have a conversation with our members of Congress about the workforce needs and, you know, what can we do to help the future. Yes, ma'am.
Laura, some of the things that we're doing with our PBHCI grant are trying to cross-train wherever we can, but also beginning to really educate the consumers who we're serving. So we're teaching them to take their own blood pressure, we're helping them understand what the lab work means, and they're beginning to talk that talk. So that's helpful because then they are really more partners in their healthcare. In terms of the cross-training, we've taken, you know, the basic health data for each of the grantees in our project and given that health data out to the treatment teams. But we realized that our therapists and social workers may not know what to do with some of that. So then we've given them a quick list of, if you're treatment planning around a wellness goal, these are quick things you could talk to the client about in terms of reducing high cholesterol or those kind of things, so that it's quick and easy and accessible, because we're all in these high levels of productivity of having to see a client every hour, and nobody has time to stop all the time and do training. So, so if they've got their laundry list with them, and they've got the client, and they can see the client's health issues, they can begin to integrate those health goals.
And that's great, and that's why, you know, I'm really excited about the case to care manager is helping them to feel comfortable. Because, you know, honestly, a lot of folks, they come to us because they do think of us as their health home. They think of us as their friends, and they will come to us and say, you know, I got this lab test in the mail. What does it mean? And we want to be able to help. We want to be able to have all the answers. And so how do we help our staff to kind of say, yes, this lab test, those, you know, numbers are about your cholesterol. These are about your diabetes. Oh, look, that's a little high. You might want to ask your physician about that. And there's a colleague of ours, Tony. If you can't get it on a one-page laminate, then it's not worth having. So, you know, as much as you can get on a one-page laminate as a tool with, you know, tips or, you know, this kind of health information for them to, or sample questions that they can have with their clients, the better. Because we always know, yes, one-page laminates, that's the motto we try to live by. But it's hard when you work on government projects. One page. Other things that you've done, by the way, I just want to ask a question. You know, if anybody else here wanted to, you know, come to your site or have one of your staff that's done some of that training, would they be able to talk to you?
Dr. Olson and her team on Monday. So yeah, we would certainly welcome people to contact us and talk about what we've been doing over the past year and a half.
So I really encourage you, you know, in terms of if you know, with this grant or other programs, if you hear of an agency that's really doing some innovative work with their staff, you know, we're a small community. We hear a lot of rumors about like, wow, they're doing something really different over at this health center or over at this treatment center. You know, let's go check it out. Don't be afraid to make a phone call, have lunch, or be able to send a team over to kind of just see what they're doing. It's a great strategy. So I threw this in, it's off topic, but it's really about rapid cycle improvement models, and I really encourage you to be thinking about it, both in terms of some of these workforce pieces. What are some of, again, thinking about that elephant, what's that one bite you can take that you can plan an intervention around workforce? So maybe you want to do some of this cross-training across your staff. Try it out, study it, did it work? And then make changes. You know, go through the rapid cycle improvement model and the process, the plan, do, study, act. And then also train your staff. I mean, I think one of the things we have to think about with our workforce is no matter what, healthcare reform is going to change the landscape locally, at the state level, federally. You know, how do we become adept at change? And how do we become adept at constantly trying new things? You guys have heard of the TED Talks? I just watched one yesterday that I loved, and it was on about the whole area of failure. And that this country is built on the idea that we fail, trial and error. That we try, we fail, we try it again. And that we cannot be afraid to try and fail. And I think we have to really embed that with our team. That, you know, let's try something different. And if it doesn't work out, that's okay. We'll come back around to it. But really, it's that culture of a change environment. And then lastly here, we have our website. All the reports and materials that I have on here are available on the website. And if you can't find it, just give me a call or email. You know, I'll send it to you directly, so you don't have to navigate that. I'm trying to be high tech. This is brand new, a QR code. So for those of you that have smartphones, you'll be able to put up your phone, and it'll go directly to the website, or you can send that link off to your staff. So we're trying to get fancy here with you. Great, well, yes?
I'm thinking of, in addition or akin to cross-training, I'm thinking of cross-pollination. And for example, I'm thinking of a halfway house, a little bit of outpatient treatment in a fairly rural Maryland county. Business for years, well connected with criminal justice. No ancillary care of this kind, very frightening to staff and program thing. And when you mention about like the National Health
Service Corps,
would this be the kind of organization that could benefit from those professional services as well as providing, if not training, at least pollination for the people who would be giving those services? Could this be the kind of model that you're suggesting on a small but practical scale?
You know, I think your model is outside the box. So I think, you know, in trying to become a site, you have to really articulate what is, you know, how does it fit? And that's where I think you get your primary care office or the kind of official designees for technical assistance around this to give you feedback to say, okay, we're really going outside the box here, but does it still work? Does it meet the letter of the law in terms of what you're trying to achieve or how you're trying to structure it? So I think, again, the trial and error, feel free.
Would that contact or suggest they contact to expand that box to include them?
It's a federal program, so there's some challenges there, but there's a lot of connection at the state level. Again, with this program and your, I'm sorry, your name again? Your new contact on workforce? So I would suggest if Jackie would be willing to talk about this and do some research and help have that conversation at the state level to see if there are some options.
Thank you.
And with that, I'm done. Thank you very much for your time. Appreciate it.